In the sense of all the fears that you potentially hear about prostate cancer and what you have to go through, I felt really relieved that those fears didn't really happen. It's an opportunity because now I can have a conversation with people.
Hello, and welcome back to 20-Minute Health Talk and part 2 of our series on prostate cancer. I'm your host, Sandra Lindsay. When it comes to prostate cancer, the most powerful voices are often those of the men who have been through it themselves. Today, we're honored to welcome my colleague, Mitch Cornett, Northwell's Vice President for Community and Strategic Partnerships in the Institute for Community Health and Wellness. Mitch has walked this journey himself and will share his experience of navigating prostate cancer from diagnosis to treatment and beyond. Dr. Samir Taneja, one of the nation's leading experts in urology and prostate cancer care, joins Mitch to help us understand the medical side of the journey. Together, we'll connect science and the human story. Well, hello, gentlemen. Mitch, it's great to have you. Thanks for agreeing to share your story with us. We can't wait to hear it. Dr. Taneja, thanks again for rejoining us to kind of marry the clinical aspect of prostate cancer with the personal story that Mitch will share with us today. So let's jump right in, Mitch. Tell us about your journey. When were you first diagnosed? When you heard the words, you have prostate cancer, what was going through your mind? What were your first reactions?
What started was me wanting to be healthier. So went to my primary care. Before that, I really wasn't very active in going to get my, annuals and things that you're supposed to do. I went to my primary care doc and he was like, hey, when I'm looking at what you're doing, you're not doing the right things. You're overweight, your lab works are really bad. And, if you, and I have 3 daughters, and he always used that as a plug. He's like, well, if you want to see, if you want to walk them down the aisle, you need to start changing. So I got more aggressive with my healthcare, doing my annual. So I went on my annual in January of 2023. Everything was fine, no issues. And, every couple of months I would come back and get, some lab work just to make everything was going good. In November, went back for him again, and he did some lab work, and he, since I was going to go back in January, he thought, hey, let's do all your lab work so that you don't have to come back and do your annual. So that included doing my PSA. Did the PSA, got a phone call from him, and he said, hey, your PSA is really high. And I said, what do you mean it's high? Because before it was normal, like, what he deemed was normal. And he said, it was really high. Let's do it again. And so we did it again, and it was still high. I think it was like 5.9, and I think the second time we did it was like 6.1 around. And he felt, he was like, you need to go see a urologist. Lucky for me, being at Northwell, life is very easy. I was able to reach out to the Smith Institute and was able to go see Dr. Schwartz. We, went through what Northwell has as the RDP program, right? So I went and got an MRI done. And unfortunately, in the MRI, he saw some lesions, so he did a biopsy, and the results of the biopsy showed I had cancer.
What were your first reactions?
My work is really focused on the community and community health, and you hear the stories, and but you don't think it's going to be you.
Right.
You know what I mean? And so, it was one of those things where you're frozen for a little bit. I had this kind of thought process as well. I have cancer. I'm always here trying to help people about screenings and everything out to prevent it. And here I am, in that situation now with cancer. So it was a little shocking. But, again, because of the people I work with and in my own personal research, I was nervous, but I wasn't nervous because I felt I caught it early. Right? Because literally, it was like 11 months later, so I'm thinking that I caught it early.
When you first went to the urologist, because you're in community health, did you know a lot about prostate cancer?
Not in detail. For me, it was more of, I know the importance of screenings, and I know the stages, because I know cancer, because I do a lot of work in cancer, so I know there are different stages. So for me, the first thing was, how advanced was it? I knew the word advanced in my mind. That would kind of tell me where he is. When he said it was localized, that it was still within the prostate, then to me, that's a good thing. The opportunity for me to have a normal life afterwards was much better than if it wasn't, if it was a stage 2 or something like that.
And did you know other men who had had prostate cancer before that?
So it's very interesting. My dad had it, but I didn't know he had it. I mean, you know, and that's why I say it's always important to know your history.
Right.
My parents were trying to
Very
protect me.
private.
Right, and so when I was actually at the surgery when my dad had his prostate removed, but I didn't know that because they said it was kidney stones. I'm a Haitian background, so in the Caribbean family, we keep things together, and it's to protect the children. And I have to be honest with you, I did something very similar. I didn't let my girls know that I was diagnosed until they got back for the holidays because they all had exams. It's so funny because when I had to tell my mom, and then that's when I found out my dad had it too. So, you know,
it's so interesting because it touches on so many different things. I hear those types of stories a lot, but of course if you knew your dad had prostate cancer, you may have been screening even more aggressively from a younger age, which is what we want men to do when they know their father has prostate cancer.
Right.
But it's also very common, I think, among men when they're confronted with a health problem. Of course they're fearful of mortality, but often because men view themselves as responsible for the well-being of all those around them, their immediate thoughts are how to navigate without disrupting the lives of those around them, and making sure everybody's taken care of. Oh, you know, my daughters are not married yet. Are there enough assets aside for them? Oh, I don't want to disrupt my daughter's testing schedule. Oh, you know, I'm reluctant to tell my wife because of whatever reasons.
Right.
And that's it's something of a common sentiment I see a lot among men. They'll often try to start out on their own, you know, rather than seeking the support of those around them.
When I finally had to tell my wife, it was not something that was done immediately. Like I had to process it myself, and I really waited until after my conversation with Dr. Schwartz, my urologist, to make sure I knew all the things because the questions were going to come.
I wanted to bring Dr. Tanasia in to talk about PSA and what's normal PSA, and, you know, Mitch's account that he went from normal to 11 months later, a very high PSA, and how often we see that.
So PSA stands for prostate-specific antigen. An antigen is basically a protein on the surface of a cell. And this particular protein was discovered in the 90s, in 89, and then clinically utilized in the early 90s. It was discovered that PSA in the bloodstream, the level of PSA in the bloodstream, seemed to correlate with the likelihood of having prostate cancer. Now, interestingly, PSA is a normal protein. It falls into a family of proteins called the kallikrein proteins, which are in the semen and are part of the enzymes that liquefy the semen to pass through the cervix. Most of a man's PSA is ejaculated out, but a small amount gets into the bloodstream. It's normal to have a small amount of PSA in the bloodstream because as a prostate gets bigger, a man might have PSA. If their prostate's inflamed for some reason, it may leak PSA into the bloodstream. But we've learned over the years that there probably is no real normal, that each level of PSA predicts a slightly increased risk. And as a man grows older, his PSA is going to go up. So, for example, a PSA of 6 in your age group would be concerning, but in an 80-year-old would not be concerning. That might be normal for that age. So we tend to now think of PSA in that way. When a man is in his 50s, we'd love to see it below 2.5. Ideally, we'd love to see it below 1. That predicts the lowest risk. If a man is 45 and has a PSA of 1.5, he's at much higher likelihood of prostate cancer within his lifetime, as an example. So the PSA number has to be viewed in the individual patient, has to be viewed in the history. It's going to go up a little bit each year, but if it's going up too fast,
then there's a
we
problem.
might even be worried at 2.5 or 3. If Mitch was 1.3 and in November was 2.5, that would have worried me.
What would you do next?
So that's changed with time. It used to be in the 90s, because we didn't have imaging, we would have jumped straight into a biopsy. Nowadays, we start with an MRI. And MRI can give you a good roadmap if there's an area of concern. As Mitch pointed out in his prostate, the urologist can target that area and get a very accurate biopsy. And at least in my belief, if the MRI is normal, it may give you the opportunity to say, look, we don't need to do a biopsy right now.
So Mitch, in your case, you did all your testing and you had a biopsy done. But before that, how did you break the news to your wife, and what was her reaction?
Before the biopsy, she basically, she was calm. My wife's a very spiritual woman. So, she knows, and she'll always say, God doesn't give you something that you can't handle. But she's also very confident in the sense that, I work at Northwell, and so I'm going to have the best options for me. And so those are critically important for her.
So what treatment options were presented to you, and how did you ultimately make a choice, and what choice did you make?
So, it's interesting because I didn't, when I met with Dr. Schwartz, my thought was like, what is the best, in his opinion, the quickest and best way to just get rid of it? I don't want, because I did my own research, and I do know, like, as long as it's localized within the prostate, it's a good thing. It's when it starts to spread outside. So since it was localized, my thought was, what are the options in terms of removal? And that was in my head to ask him. And so we decided that, we'd go with the robotic surgery and have it removed. I felt, to me, knowing it was removed, then, there is still a chance it could come back, because, like, in my own research, I know sometimes the cells may actually go through the bodies and you may find out. But I felt this was the best option, right? Get it removed. Hopefully no cells have gotten through the body, and so I can be good to go.
Dr. Tanisha, I'd like you to react to Mitch's account there, and specifically talk about robotic versus radical prostatectomy.
I think a couple things stood out. One is that men often come in, as Mitch did, with a preconceived idea of how they want to handle their cancer. Sometimes that's based on their own conception. Sometimes it's based on personal experience. My neighbor had X treatment and they did well, and that's what I want. But a few of the words you said, I hear a lot. What can I do to just put it behind me? I'll deal with the consequences, right? And that's a common sentiment among younger men in particular who have young kids, or they're very focused on their mortality. Older men sometimes will think, well, I've got only a certain number of years left and I want quality of life. And they're going to shy away a little bit from surgery, as an example sometimes. So part of our job as a urologist in that scenario is to make sure the patient doesn't have preconceived misconceptions about the outcomes. Yes, surgery can be a way to put it behind you, but it could also fail, right? If there's disease that's outside the prostate or microscopic cells that are left behind. Yes, you most certainly may recover sexual function with time, but you may not. So our job as a good urologist is to present the balanced discussion, because one of the very common things after surgical treatment or any treatment is decisional regret. We measure that in studies. I don't want my patients to spend the rest of their life in a rocking chair saying, why the heck did I do that?
Yeah.
Now, having said that, I do think we've gotten a lot better at the surgery over many years, and certainly there is a good likelihood of recovery in a number of patients. Robotics is the way that most of us do the surgery now. I'm not sure there's compelling evidence that it's all radical, by the way. Radical just means you're removing the whole prostate.
Okay.
Robotic means that you're doing it through puncture incisions using a surgical robot. In the hands of a very good surgeon who's experienced, it can be done well. What robotics perhaps offers us is less blood loss during the surgery, a little bit more rapid convalescence, and in my opinion, magnified view, which allows us to see and deal with tissues better. I've been doing prostatectomies for over 30 years, and the first decade was all open, and the last 2 decades have been all robotic. And I think that's what it affords me, a better tool to do the operation.
So, Mitch, looking back at your journey, what surprised you the most about your treatment? How do you feel now emotionally, physically, spiritually?
It's interesting what Doc said because, I kind of felt that I had like the best journey. My surgery, was a little challenging a little bit in the beginning. I think the worst part is having a catheter. That's from a male's perspective. But after that,
I say it's a tube where you're not supposed to have a tube.
It's exactly it. It's a tube where you're not supposed to have a tube, and and there's no way to kind of prepare for it. But you take that away, everything kind of went as conversations I had with my doctor, and I think the other thing that was really good was we did pre-rehab. Really trying to build up the strength of the bladder, doing Kegel exercises. I think that was very beneficial for me, because, I would probably say 4 months after, I really didn't have an incontinence issue. The Kegel exercise that actually helped, and the bladder leak didn't happen as bad as I thought it was going to be. It allowed me to get back to work. And that to me was the biggest piece, is to get back to normalcy, right?
Mm-hmm.
And I love my job. I love to be out in the community. I love to be working with my colleagues. And I have to say that journey allowed me to do it quicker. Doing the pre-rehab and then following up with the rehab afterwards. So I think I was back to work a lot sooner than potentially you probably would have expected. In the sense of all the fears that you potentially hear about prostate cancer and what you have to go through, I felt really relieved that those fears didn't really happen. Again, to what Doc said, my experience is not going to be exactly for the next person's experience, but at least I can have a conversation and say, look, you have options. You need to, walk it through with your provider and talk it through.
It sounds like Mitch's wasn't so bad in the beginning. Some men may leak nearly everything in the beginning. Some may be nearly dry from the start. There's great variability. The good news is that that's in recent years at least, that seems to be to me to be a more reproducible outcome, meaning that the vast majority of men will regain good control. Either they'll be completely dry, probably in about 80% of patients, and the remainder will report some degree of rare occasional dribble or squirt. And there's only probably, in most people's experience, less than 5% of patients who have very bothersome leakage after the first year. But having said that, it is a substantial side effect if you end up with permanent leakage after a prostatectomy and are in diapers or pads for the rest of your life. So it is a major education point beforehand and something that influences people's decision process.
Wow. Well, thank you so much to you both for being so open and honest and informative. To wrap up, if you could leave one powerful, concise message for men listening today who may be facing this diagnosis, Mitch, we'll start with you. What would that be?
Well, if they're facing a diagnosis, I think the best thing is be open and honest about how you're feeling, and have a very good conversation with first your family and then with your provider. I think those are, to me, the biggest things that I took out of it.
And Dr. Taneja, your final message to our listeners.
Well, if you're confronted with a diagnosis, I think there are a couple things to keep in mind. One, have a good relationship with your physician. So feel comfortable with the person who's counseling you. Mitchell had a lot of trust in the person who was caring for him, and that's important. Always be wary if someone's telling you there's only one solution to your problem. Surgery, radiation, whatever. Everybody has options, and they should explore the options, whether that requires second opinions or not. And I would encourage men to take along their loved ones on the consultation. And having your loved ones around you to ask questions that you might forget or to hear things that you're not necessarily hearing can be very useful. It also can alleviate their stresses too,
Right.
that they get a chance to ask their questions.
Well, thank you so much, gentlemen. And to our listeners, thank you for listening. Until next time, I'm your host, Sandra Lindsay.